All right, so to get started, if I may, tonight we're going to be talking about intimacy. I'm going to start with the medical side, Maddie's going to talk about the practical side, and Dick's going to come in and preach us and knock us out. So that's the way we're going to do it. But to kind of line things up before we actually get into cancer, the intimacy thief, we're going to talk a little bit about the history, the medical history of oncology. So when doctors first started managing patients with cancer, they thought more was more. So if a woman came in with breast cancer, even if it was a small breast cancer, chances are she'd get her breast taken off, her chest wall taken off, all of the fascia taken out, all the lymph nodes taken out, and leaving her with basically just maybe a couple of millimeters of the skin, which was basically between the exterior world and the lung. And invariably, it was painful. Invariably, there would be a tremendous amount of swelling or edema. And invariably, it didn't make a difference. They would, if they had advanced disease, they would die whether they had a mastectomy or didn't have a mastectomy. So that concept, what we call, Dr. Yan and I call like a Holstedian view, sort of a very radical view of a disfiguring, disturbing, ineffective procedure. Back in the 1980s, oncologists started taking a turn, sort of like a full 180-degree turn from radical to reticent. So from radical procedures to more conservative procedures, looking at trying to find ways to continue to give patients high survival rates, effective treatments without the disfiguration, without that loss of quality of life. More was more became less is more. And that's sort of the way things went. And it went quite well, actually. I always quote, the NSABP trials with Bernie Fisher et al., who published that famous study saying that mastectomy was as equivalent to just a lumpectomy with radiation therapy and sometimes with chemotherapy. Actually, I was part of that study. I was the guy holding the retractors while all the doctors were cutting out the breast tumors. And they would hit me with their hands and kick me and say I wasn't doing a good job. And I wanted to say a lot of good things, but I didn't. So I'm actually part of that trial, which tells you several things. Does it tell you I'm famous? No. My name's not on the paper. Does it tell you that I'm rich? Rich? Look at me. Okay. My Subaru is the one. Okay. No. It just tells you that I was in the right place at the right time, is what it tells you, and trained with some really good people. So, in addition to the concept of doing less of a radical procedure, and this is all actually going to make sense, believe me, there was the push toward early detection. So trying to find cancer at the most early stage to allow for these more conservative procedures. So mammograms became very crucial and important in order to try to get women into an earlier stage. Pap smears should have or will or hopefully sometime in the future eradicate cervical cancer completely. PSAs should allow men to be diagnosed with prostate cancers at a much earlier age. When I first started training, most men came in with a stage C or stage 3 or 4 prostate cancer. 90% of our patients now, right, Easy, come in with a stage 2. Pretty much almost everybody. Occult blood colonoscopy, rectal cancer, trying to keep rectal cancer diagnosed early. And what's in store in the future, we hope, is that we'll all be genetically tested. We'll be able to have our genome known. So we'll be able to, the doctors will be able to have preventative mechanisms in finding out or selecting which patients are at higher risk for what type of cancer. So the future is very, very exciting, and that's really the direction. But I have that famous slide, which I don't have tonight, but if you can imagine, the Tom Hanks on the island and being shipwrecked. All of the stuff that I just told you is all well and good. and it certainly is. But there is a disconnect. What happens once that patient reaches the end of their active treatment? So they've had their lumpectomy, they've had their radiation therapy for prostate cancer, they have all of this love, all of this support, all of this guidance, all of this access, right? Access to medical care 24/7. And then all of a sudden on your graduation day, there's tears. But they're not tears of joy. They're tears of absolute fear, fright, whatever adjective you want to put in. It is horrible because that is an unknown territory for survivors. That is the time when you feel very much like you've left the womb and now you're into the real bloody reality, the reality of your cancer survivorship. There's a deflation. And I think the word that I wrote down that best sort of fits my observation of this phenomenon is an isolation. You feel very isolated. And I've tried to put together a bunch of vignettes to try to describe this, you know, all these things that we're talking about, where I had a patient who finished radiation, and again, going back to what I just described, tears just flowing, sobbing, really, really hard grief. And at first I was smiling, I'm thinking, wow, this is great, you got through, this is fantastic. She was mortified, she was so scared. And we all had to really just hug her and give her reinforcement and have her come back weekly checks instead of every month, because that just wouldn't have worked for her. So there's something missing. What is missing here is that what survivors need that they're not getting is what's called a survivorship plan. That has not happened yet. It has happened in a few centers, but it hasn't happened anywhere yet. And I'm going to tell you how Kroc is going to bring survivorship planning into Orange County, into the Hudson Valley. But survivorship plans are only as good as the people doing the survivorship plans. So what the hospitals are going to start doing is they're going to start doing survivorship planning, but only because they have to, not because it's the right thing to do. They're going to basically rubber stamp a survivorship plan that's really not going to be anything more than superficial. What I'm talking about here, and this information that we're going to be discussing about intimacy, really gets into the deepness and the actual visceral abscess of all of these things that you guys experience, those special needs you guys have as survivors. And that's what has to be, that is what has to be addressed. It has to be addressed by time. Your practitioners have to spend more than 7 minutes giving you a hug and saying, good luck in your survivorship, you're great. It has to take into account expertise. The doctors can't just be family practitioners, and I have no problem with family practitioners, but when it comes to cancer, they're not going to be able to be tuned in to the things that you guys need. There's going to have to be money put into this. The government is going to have to spend the time to put the money into survivorship planning, and there's got to be a continuity. If patient X gets through treatment with 15 different treatment-related side effects, which fall into the realm of about 5 or 6 different subspecialists, there's no continuity. The urologist isn't going to know, what the pain management doctor isn't going to know, what the proctologist isn't going to know, what the cardiologist isn't going to know. No one is going to be communicating. That has to change. And there has to be passion. Passion has to be brought back into the survivor's arena to help you guys plan your survivorship and survive your survivorship. I've seen more patients survive their cancers but live in absolute despair in their survivorship because of the isolation that they feel. And this is what we're going to hit today. This is the first level, that thievery that cancer does to you guys, that thievery of intimacy, and that's what we're going to talk about first. So, Is there a need for this? I want to give credit to my wife for doing actually some research for me. She's got a master's in public health from an Ivy League school, right? Thanks for the help. When Croc started in 1999, there were 8 million survivors. In 2012, where we sit today, there's double that, almost double that number. There's 14 million survivors. That's 4% of the population are survivors of cancer. Think about that for a second. 4%, that's a ton of people. 14 million people have survivorship needs that have been completely not addressed. The complexity of survivorship is multifactorial. It goes way beyond anything we could even imagine. If you look at the psychological side, you have the distress of your diagnosis. You have a loss of control of your treatments. You have anxiety, depression. You've lost your enjoyment, your leisure activities. There's a fear of reoccurrence. Every day you guys wake up. Is this son of a bitch going to come back today? If you have a headache and I have a headache, I'm going to think that I have a sinus infection. You're going to think you have brain mets. If I have a pain in my arm and you have a pain in your arm, I'm going to think bursitis. You're going to think bone metastasis. Physical side, your functional activities are affected. Your strength, you have fatigue. You need sleep, but you can't sleep, but you can't rest. There's issues with fertility. There's issues with pain. There's issues all across your physical health. Your physical health has now become so complex that a normal general internist isn't going to know how to deal with you. There's social issues, there's family distress, there's roles, relationships that have been completely decimated. Affectation, sexual function, we're going to be talking about that tonight. Your appearance, we're going to be talking about tonight. Enjoyment, isolation. Your money, you're putting a ton of your money either into your health insurance or what your health insurance doesn't cover. So your whole budgets, everything in your financial life is in havoc. And your work life, that which is a huge part of our being, is our work, and that's affected as well. On a spiritual side, Dick is going to address the meaning of illness, your thoughts of religiousness, how you view God. Are you angry at God? Are you angry at yourself? Hope, uncertainty, inner strength. When you look at the data, when you look at the Livestrong data, patients whose physical concerns have been addressed by their doctors during their treatments, which have, again, I'm not knocking the treatments, they're fantastic. More patients are surviving more complex cancers, but so many people have not gotten any help with energy, 59%, concentration, 55%, sexual functioning, 46%, neuropathies, 42%, pain, 34%. At least 1 in 3 patients do not have their concerns addressed at all. Emotional concerns are even worse. Fear of recurrence is not addressed 80% of the time. Grief, 70% of the time. Appearance, 60% of the time. Family member risk, 50% of the time. And sadness and depression, 50% of the time. Practical concerns, school issues, employment issues, debt, insurance. Again, more than 50% of those concerns are not addressed at all. There's a humongous void here. This is the void that needs to be filled. These are the people that have not received help where they need help. And that's what we're going to try to do tonight, is start to delineate some of these small pockets and slowly gain momentum and traction to give you guys the information that you need to get the insight that you deserve, to get the treatment that you so much need and deserve. So, I mean, let's talk about this for a second. I want this to be an interactive session. How do you guys define intimacy? Can I see some thoughts? If you guys...
It's closeness, just talking.
Okay. Shoot them out. Come on, guys. I'm working my ass off up here.
Work a little harder.
physically or emotionally.
Thank you.
Laying out your guard, opening yourself up to somebody.
So I put down the words, does anyone equate lust with intimacy?
Absolutely.
We did.
That's something else.
How about sex with intimacy?
Yeah.
Okay. Is it more than just lust and sex?
Yes.
Okay, well, I'm asking. So let's go to Merriam-Webster. What do you think? So Webster says that intimacy is the state of being intimate. Thank you.
Do you think it might involve aspects of intimacy?
Familiarity. What I found actually, to be honestly, what I really found valuable in Webster was looking at synonyms, and I thought the synonyms unique was the following: a sense of belonging. How about this word? This was my favorite: chumminess. I thought that was wonderful. Intimacy, chumminess, closeness, inseparability, familiarity, nearness. And there was only one antonym, and that was distance. So I think that's a really, really important definition, because it really takes intimacy out of the old-fashioned lust, sex sort of thought process and expands it to so much more than that. And I think that's beautiful, and I really believe that. I believe that intimacy is so much more. And as I alluded to in the beginning of the lecture, intimacy could be with your partner, your spouse. It could be with your children. It could be with your coworkers. It could be with your friends. It could be with your neighbors. It could be with a stranger. Or most importantly, I think intimacy could also relate to how you are with yourself, within yourself, just how you feel about yourself. But where is the breach? So now we've talked about the history of oncology. We've talked about sort of the genesis of how cancer care and focus has changed. We've talked about the obvious needs that are not being met. We have a really good mechanism in our minds of defining things but not having solutions to things. So let's look at where the breach is, this thievery. So I personally came up with 5 that I thought that I would like to discuss with you guys. The medical issues we're going to talk about, the psychological / fear, the psychological / projection, the spiritual, the death and dying, which I'm going to let Dick really focus on, and the emotional, which I'm going to let Maddie focus on. And the answer to me is intimacy is really all of the above. It's everything you said, everything I said, everything Webster said, and then add everything else together. It's really about yourself. So I'm going to start in a surprising place. I'm going to start in a place you're never going to believe. Let's talk about projection. What if I were to tell you guys that the people that you think, as survivors, the people that you think are your most important resource, are your biggest cheerleaders, are the ones who wish you the best? What if I told you that was true with a footnote? Would you guys believe me? Because it actually is true. The cancer journey doesn't just affect the cancer victim. It also affects all of the people who have, quote unquote, intimate relationships with that survivor. Going back to my friend Merriam-Webster, projection is the attribution of one's own ideas, feelings, or attitudes to other people or objects, especially the extension and externalization of blame, guilt, or responsibility as a defense mechanism against anxiety. Let me say that again, this is really important. The externalization of blame, guilt, or responsibility as a defense against anxiety. That is the most powerful paradox that I'm aware of as a physician, is to know that there's an underlying dynamic going on between my patient and their loved ones, which is completely normal, which is completely healthy, but it needs to be discussed. And that's where we're going to start tonight. So, vignette number 2. Recently, I met a couple who've been married for 60 years. They absolutely love each other. It's not you guys, but I know you've been married. I don't want you to think that I'm talking about you guys. But I would see their love, and over time, see, radiation therapy is really cool, because I get to see everybody every day. So you can't hide from me. I can see you on a good day, I'll see you on a bad day, I'll see you interact with your family members, and I'll see everything. And one day, I felt their love, but one day there was a great distance. There was sort of an angst, there was an anxiety between this couple. She was really pissed that he lost 2 more pounds that week. She was really pissed that he didn't eat the shit she wanted him to eat. He was really pissed because she was pissed. And he had enough problems just trying to swallow his saliva, never mind the Hershey bars, the half-a-ham sandwiches, and the milkshakes that she went out of her way to make. So I'm seeing this sort of loss of control on one side and this micromanagement issue on the other side. I'm seeing a waterfall. I'm seeing a cascade of feelings that are really, really, really uncomfortable. It's a waterfall of anger, of guilt, of fear, of indignation, of blame. It is awful, and everybody feels awful about it. The patient feels bad about it. The family member feels bad about it. Do you guys think that there's a disruption in intimacy from that? You better believe it. Anger. Why did you get this cancer? How could you have gotten this cancer? You should have drank less, you should have ate less, you should have exercised more, you should have slept more, you should have went to your doctor more. Indignation. Now look at what this cancer is going to do to me. Our whole lifestyle is absolutely interrupted. That vacation that I've been looking forward to since the beginning of time ain't going to happen. We're spending all of our goddamn money on health care, and we're not going to have money to put the kids through college. I was a kid when my brother was diagnosed with cancer, and he stole my childhood from me. All we did was go to doctors for my brother. I never got to go to the prom. I never got to do anything with my friends, and I had to always stay home and watch my brother. Fear. What am I going to do without you? Now the spouse, the partner, the friend, the family member has to think about the potential of life without their loved one. Not fun. Not fun. Guilt. There is nothing that a loved one can do for a cancer survivor because they just can't. They're not oncologic surgeons, oncologists, radiation therapists. They're just people, normal people, and they have no control over this cancer. Zero. That makes them feel guilty. If the person who has these feelings actually has the insight that they're having these feelings of indignation, anger, blame, guilt, they're going to feel terrible about it. And that's just going to basically feed guilt upon guilt. Blame. How about this one? If only I had made you go to the doctor. If only I had made you realize that that cough was worse than it was. If I only stopped you from smoking or eating or this or that or whatever behavior might be associated with that cancer. Imagine that blame that spouse or partner or friend has Do you think that might interrupt intimacy? Do you think? I think so. Fear, as we talked about, psychological projection, psychological fear. Cancer is a 4-letter word. We've talked about this for 14 years. We've been at Croc. We've been through it. We've discussed it. We turned it inside out. There's nothing I can do, even after 14 years of advocacy, that's going to make the word cancer any less scary. I hope that there are moments like these lectures or when I'm in a room with a patient where for a temporary short amount of time, I might be able to distract you and think about something else or reassure you or do something positive to help you with that fear. But the truth of the matter is, what fear does is it takes away that complete sort of fantasy world that all of us live in. There is no guarantee in life, but we who don't have cancer are very easily distracted toward complete dissociation or complete denial of this. When you get smacked in the head with the C word, that denial mechanism doesn't exist anymore. The reality of life and death and today and tomorrow, they basically come and smack you, and they're right in front of you, and they're not going anywhere. They're just staying with you. So basically, a patient of mine who then moved to a different state, had a different oncologist, terrible breast cancer, metastatic, all she was focused on was dying. Even though she was in remission, she was feeling fantastic. Every day, she would talk to her doctor down there, I'm going to die, I'm going to die, I'm going to die. The doctor would say, you're not going to die, you're not going to die, you're not going to die. She was 40, he was 40. Guess who died? The doctor died. The doctor fell off his mountain bike, cracked his head open, he's dead. 5 years later, she's still alive. So cancer totally messes with your mind. And do you think that affects intimacy? Spirituality. Why did you do this to me? This is such a bad time in my life. There's bargaining, there's anger, there's despair, there's hatred. I went to church, I did my rosaries, I went to synagogue, I got my bar mitzvah, I got bris, and damn, they took too much. I endured that. Moses for what? There's an immediate life evaluation, self-judgment, vignette. I had a patient, very successful man, lives up in Orange County, commutes to the city, stockbroker, incredibly wealthy, but didn't live life by the rules. Did a ton of bad stuff. He cheated on his wife. He got divorced. He ended up screwing his partners. He sued people. He stole money. He did everything you can think of to be a bad guy. Now he's got stage 4 cancer. He's going to die. He ain't happy about that. He has to come to grips with that spiritual thing of that sort of judgment, that karma, that whole sort of thing about that death and dying. Do you think that that's going to give him some problems relating to someone in an intimate way? I absolutely think so. On the emotional side, let's talk about self-image, self-confidence, self-esteem. Maddie's going to hit on this directly, but just to kind of put it into context as it relates to the medical side. Young patient in her 30s, stage 2 breast cancer, has a mastectomy and an immediate reconstruction. Very unhappy with herself, very unhappy with what she looks like. She will not date. She will not talk to a man, will not do anything social with her friends. She feels that she is a mutant. She feels that she is absolutely hideous and horrible, and there's nothing that anybody can do to change her mind. Tits sell. Let me tell you something. Look at any magazine in Western society. Anybody. It's all about the cleavage. It's all about the breasts. We have absolutely Yeah, I'm talking exactly about your numbers. My favorite movie, one of the lines is, "Man, those fish tacos last night were great." And the response was, "Yeah, they were the tits." That means that they were so good. They were the best fish tacos they ever had. What movie was that from? I love you, man. So let's go to the medical side. I'm going to break it down by site, and we're all going to kind of talk about some of the inherent difficulties and the thievery that cancer does to people who have these types of particular cancers. And already we're making progress, because already, do you notice we're going from intimacy from a general global view to intimacy to a very specific view, a special specific need for that particular patient. So we're going to talk about head and neck, we're going to talk about breast, we're going to talk about lung and chest, abdomen, GI tumors, pelvic tumors, GYN, pelvic tumors, GU, so GYN gynecology, right? GU, genitourinary for men, women. Skin, sarcoma cancers, lymphomas and leukemias. We're going to talk about metastatic disease. We're going to talk about childhood cancers. So, do we have any head and necks here? I have a thyroid. Do I have any other head and necks? Okay, thyroid. Marianne, head and neck. All right. How about you get head and neck cancer? How's that sound? So I've got 2 thyroid patients who don't have any capacity to generate their own thyroid hormone. Thyroid hormone is basically our jump starter. That's basically what makes us move in the morning. And all of a sudden, these guys don't have an organ to produce this thyroid hormone. So they have to take the next best thing, which is a pill. Every day, here is what your body should be making. And we're hoping, and we're crossing our fingers, that that'll be the right dose for you, and that that'll make you feel good. How about if you had a laryngectomy? Communicating. How does that sound? You think that would affect your intimacy? How about if you have a tracheostomy and you gotta talk like this? You think that would affect the way you communicate with people? How about all that, what I call the clumps, all of the expectoration and all the saliva and all the gunk that's in there and all the dried inspissated material? Do you think that might interrupt intimacy? I do. How about a peg tube? How about nutritional issues? How about neck fibrosis, so the neck becomes scarred? My buddy here, who I burned his neck to hell. How about all that dryness of the mouth? When Matty and I hike, he takes a water bottle, but not to hydrate himself, because he doesn't have any spit left. That affects your quality of life. That affects your intimacy. How about pain? How about being in pain every day, every moment? Do you think that might interrupt your interaction with people? Lung cancer. How about having shortness of breath, right? So I can see Mr. Charette over there. Say you didn't have lung cancer. I'm just using you as an example because I want to make sure you were listening. And say Mrs. Charette, as beautiful as she is, she's waiting for him by the door. I want you to picture this. All she's wearing is a ribbon in her hair. And Mr. Charette gets up and he wants to go over and he's trying to get over there. He's trying to get... Honey, I'm coming. Metaphorically. Shortness of breath, dyspnea on exertion, and again, expectoration. Breast cancer, we're going to go right to the heart of things, right? Self-esteem, self-confidence, self-image, huge cosmetic issues. How about a woman who's young, before menopause, has chemotherapy, all of a sudden, they're postmenopausal, right? Fertility issues. How about women who have chemotherapy and they lose their hair? How do you think they feel about that? You think that that might interfere with their body image or how they feel about themselves? These are all obstacles. These are all thieveries of intimacy that cancer does to you. Abdominal, GI, esophagus, nausea, weight loss, peg tube, dysphagia, you can't eat, you really can't eat. What if you have a colostomy? That's a real mood breaker. Hey, honey. Oh, shit.
Literally.
Yeah. Diarrhea. The perineum is the soft skin between the genitals and the anus. That skin is the most sensitive skin of the body. I know from on the radiation side, when that reacts, you can't even sit down. You think that would take you out of the mood? Hemorrhoids. Who has hemorrhoids? No one will admit it, but awful, terrible things. How about being incontinent? How about having to walk around in order to get out and interface and have intimacy? You got to wear a diaper. Not good stuff. Not good stuff. Pelvis GYN. So let's talk about the ladies for a second. Terrible things happen to women's genitals and their sexual functioning after treatment. Chemotherapy, radiation therapy. There's, first of all, the aesthetic. Vulvar cancer, cervical cancer, uterine cancer. You feel defiled. You feel violated. You feel like someone has taken your womanhood, your sense of your feminine, and has taken it out and ripped it out through your throat. And now all of a sudden you're basically defeminized. The dryness, the vaginal dryness. Wet is good. Dry is bad. Dyspareunia is the fancy word for painful intercourse. So if you go through this and you want to have relations with your partner, and you just can't, or if you do because you feel you have to, but it hurts. And sex shouldn't hurt. It should feel good, and it should be a connecting process, not one that's a painful process, not one that instead of creating intimacy actually causes distance. Continence. With the men. Now, I'm not talking about Mr. Ho. I know that for sure, because this guy is a stud. But how about erectile dysfunction? I have more men who come into my office for prostate cancer who says, Doc, I would rather die. I'll die. Close your ears, girls. I'll die if I can't get a hard-on. I would rather die if I can't get an erection. If I can't have an erection, I am not a man. I am everything that I am all about revolves around this. And if you take this away from me, even if you cure my cancer, I don't care. I don't want that at all. Fertility, continence, all these sorts of things. Skin cancer, sarcomas. Imagine having a piece of your face ripped off. That's bad. That hurts. Even Mohs chemosurgery, all these things. It causes self-image issues. Sarcomas, which is cancers of the extremities, of the muscles. Weight bearing. We know Carrie, she had a fracture after her treatments for sarcoma. Orthopedic issues, range of motion issues, extremity edema, having huge elephantitis of the extremities. Terrible, terrible, terrible things that happen to people after their sarcoma and their skin cancer treatments. Lymphomas, leukemias, you're immunosuppressed. You're very, very open to infection. You're bleeding. You can bleed so easily. Contusions. Hodgkin's disease is usually, it's a bimodal disease, but usually affects the young. There's long-term morbidity to the damage that the treatments do to a Hodgkin's patient, to their heart, to their lungs, to their thyroid glands, to their fertility. There's usually chemotherapy involved that could affect fertility of these young people. These are all things that are not addressed in survivorship planning. None of these things. And every single one of these things steal your intimacy. Absolutely. Metastatic disease in and of itself has enough inherent problems. Now you're talking about pain, pain, pain. When you have metastasis to a bone, when you have metastasis to a region that's just causing you to be in constant pain no matter how much morphine you're on, and you ask your doctor, I need more morphine, you shouldn't need more morphine. Well, hello, I'm in goddamn pain. Give me the fucking drugs. I need these drugs. And your doctor looks at you like, wow, you shouldn't need that much morphine, but you do. How can you have an intimate relationship if you're in constant pain. You can't. If you have bone metastasis, liver metastasis, you're always nauseous. You have a body image issue, and imagine brain metastasis where you lose your hair and you might lose your balance and you can't walk. These all interfere with your intimacy. Childhood pediatric cancers, fertility, muscular development, all these sorts of things are part of it, and all the long-term morbidity that we've been discussing. So there is good news, everybody. There are common...
It's going to come on wrists.
Thank you, God.
There is great news here. This is a positive thought. The good news is that someone got up here to say this shit. Because someone's got to address this. We can't put our heads in the sand anymore. You guys have to advocate for yourselves. For all of these things that you're enduring, you have to advocate for yourselves. You have to have the insight. How many people have ever heard any of this before? One person.
You're the first person to address it.
Thank you.
Yes, yes.
You need to approach all of these things with humor. Right? That colostomy guy I talked about. That's funny. Right? Even though it's inopportune, you need to turn an inopportune opportunity into something that you can use and you can look back on. And flexibility. There's got to be flexibility and actual addressing all of this stuff together. So on the medical team, the good news, who was making fun of me? You were. You with the cleavage, okay. Don't forget, I have the microphone. I could ruin your night.
I've got a loud voice. It'll never happen. He would never do that.
I would never do that. The medical team. So what I'm asking you guys to do is to stand up for yourselves. What I'm asking you guys to do is demand from your physicians and your healthcare care team the 4 things we discussed. I'm demanding that you ask them for time. I am demanding that if you're having erectile dysfunction and you go to see your doctor and he wants to walk out the door after 20 seconds after he sees your PSA is okay and he doesn't want to talk to you about erectile dysfunction, you tackle him and you say, Dr. Eanelli said to tackle you. And I need you to address my erectile dysfunction. Every single thing that I talked about, the dysphagia, the fatigue, the diarrhea, the pain, the erectile dysfunction, the vaginal dryness, all of these things have cures. All of these things have treatments. You just need your doctors to spend the time with you so you can have what you deserve. You deserve intimacy. You don't deserve to have your cancer take that away from you. It's already taken a lot away from you. I believe it's enough. I think we draw our line in the sand, and that's what we ask for. We ask for what were, anybody remember the 4 things? Time, expertise, continuity, and passion. Thank you.